Yep, that's me. Welcome back to PANCE Rx, your prescription for passing the pants. We're your hosts. I'm Jade.
And I'm Autumn.
And today's episode will be a rapid review, quick script on breast disorders in honor of Breast Cancer Awareness Month.
So, how this will go is Jade and I will both take turns basically quizzing each other on all of these disorders that you see on your screen, which were taken directly from the 2025 PANCE blueprint in that order. And she will prompt me to keep going on the topics as I get them right and say I get one of them wrong because I'm not perfect. She will halt me there and teach me the points that I missed. And then vice versa, we'll switch and I'll do the same for her.
Absolutely. So I like to call this the hot seat. And Autumn, I think you should start the hot seat.
Oh, I guess I'll be in the hot seat first.
All right. So let's start with breast abscess.
Okay. So,
These are all of the topics that I need you to try to show me or tell me in the next 30 seconds.
okay. So a breast abscess is your keyword is going to be a fluctuant mass, which is if you when you think about the word fluctuant, think of like a blister, like a buoyant part under the skin. And it's usually unilateral, so on one breast, and it is caused due to inflammation. The most common etiology is going to be staph, because when in doubt,
Staff it out.
yes. And this is clinically diagnosed. So you don't need to do any testing or anything to diagnose the abscess. It's basically clinical. If you see a fluctuant mass on a breast, then it's you pretty much know it's an abscess. And then for management, we have another mnemonic. It is IND, because when you have an IND of any or an abscess of any sort, you always want to IND it. So that mnemonic is going to be heal with steel. And that also includes a fine needle aspiration if you need to, but IND is pretty standard with a scalpel. So the scalpel is the steel, and you heal it with steel.
Absolutely. So you hit it right on the nail. Our patho is, let me just move this out of the way. It's a localized pus collection, usually due to staph. When in doubt, staph it out. And it's one thing you did forget was that, well, maybe you didn't forget, but you forgot to mention that it usually a breast abscess is a complication of lactational mastitis. And so, with that, the signs and symptoms, like you said, a painful fluctuant mass with erythema and fever. Diagnosis, clinical, and an ultrasound. You don't have to get an ultrasound, but some people like to get one. And then, if it's draining or if you're draining it with a fine needle aspiration or IND, heal with steel, you want to culture it just to get antibiotic to tailor your antibiotics. And then management, you're going to do a needle aspiration or IND, obviously. You're going to do antibiotics, which are anti-staph because it is a staph, usually caused by staph. And then you want to remind the mothers to continue breastfeeding. It's not going to harm the baby. The antibiotics that we prescribe will not transfer to the baby. They're usually metabolized before it gets through the breast milk. And so continue breastfeeding as you would. And that sometimes helps with the pressure as well. Um,
Yes. Two other things I want to add. Those antibiotics will be your dicloxacin and clindamycin. Those are the two that we'll use. And then as far as the ultrasound, you will see a hypoechoic area where that abscess is.
Absolutely, absolutely. And then just to have some memory capsules here. So the first one, when in doubt, staff it out. If you don't know what is your cause and what bacteria is your cause, and you're sitting on the test in the pants and you're just like, I have no idea what this is. I'm not even gonna lie and say I know what it is. Staph. If staph is a choice and you don't know what it is, click staph because 9 times out of 10, it's staph. Now, I mean, it could be strep pneumo or strep pyogenes or some of those more common ones as well. But usually, if you don't know what it is, it's probably staph. And then, like she mentioned before as well, you want to heal with steel. Abscesses are always treated with an IND. Very good, very good, very good.
Thank God I'm off the hot seat. Oh,
Which means it's me.
okay. All right, Jade. You're still controlling over there, but I'm going to quiz you. So you have 30 seconds to tell me everything you know about these four topics of a fibroadenoma.
Okay.
And go.
So, fibroadenoma is a smooth mobile breast mass. It is more common in young women. It's estrogen dependent. Symptoms are a non-tender, smooth, mobile breast mass that fluctuates with the menstrual cycle. Diagnosis, usually clinical, ultrasound, and then treatment because it's benign. I don't think I mentioned that, but because it's benign, you're going to watch and kind of just keep monitor and keep an eye on it. You can excise it surgically if it is bothersome to the patient.
Great job. You pretty much hit all of the things. It's a benign tumor. Stromal and epithelial are the types. And then it's most common in those younger women, ages 15 to 35, I believe, are the ages. And they're estrogen sensitive, which makes sense. It's in the women aged before menopause. It is going to be painless. That is the most common thing to remember with fibroadenoma. It's painless. It's firm and it's mobile, well circumscribed. This is what they tend to some some areas call it the mouse of the breast because it's rubbery and it kind of slips through your fingers when you feel it. It's like a little mouse running away.
Hmm.
So just remember that. And then for diagnosis, clinical, but you're going to use the ultrasound to help guide that decision as well as a core needle biopsy. And then observation if it comes back typical. And then, as far as management, again, we're going to observe because it's benign, it's not too harmful. But if it does become symptomatic or super large, then we will choose to excise it.
Absolutely. Absolutely. And one thing I wanted to jump in and say before we keep going, guys, this is a very like zoomed out version of the information. When you are studying, this is an extra tool in your toolbox. It's not to be, oh, I'm going to just use this video because it has all the high yield stuff on it. No, you want to deep dive because that's how you learn, and that is what makes the information stick better. So this is just a more, like I said, a more zoomed out, like high yield, very rapid review to help aid in your studying. If you have started studying already, it helps you remember those high yield things. And if you haven't started studying already, it gives you a baseline to then deep dive into.
Absolutely.
All right, Autumn, back in the hot seat.
Alrighty.
So we just did fibroadenomas. So can you tell me about fibrocystic breast changes?
Yes. So this is another benign finding of the breast tissue. It is also hormonal related. It is more so hormonal related. And it's that fibrous tissue in your breast that is present. And a lot of women tend to feel it postmenopausal, I believe it is. And it's usually bilateral. So that's what our main thing is with the fibrocystic versus the fibroadenomas. Also, this is going to be painful. A lot of women can feel these changes around their hormonal cycles, and it's just very uncomfortable for them. And the breast will be swollen, and you'll feel these knots in your breast. You can actually feel them. And then, as far as diagnosis, it's going to be clinical as well, but ultrasound will help guide that diagnosis, and you will see the large painful cysts on the ultrasound. And then as far as management, supportive care, so NSAIDs, warm compress, supportive bra, and things of that nature.
Absolutely. So you hit everything on the nail. It is hormone related benign breast changes with fibrosis and cyst. Um, the symptoms, it's going to be bilateral, and there will be tender and lumpy. It's actually, you said postmenopausal, but it's actually worse premenstrual. So during the,
Okay.
it's also seen in younger women, or premenopausal women, because the symptoms are worse when your breasts are heavier and more tender, during your PMS week before your menstrual cycle. Diagnosis, absolutely. So it's going to be a clinical diagnosis plus or minus ultrasound if the patient feels like they want one, or if you're concerned about something else, definitely ultrasound. And then you can aspirate the cyst if it's large and painful. The difference between this and a fibroadenoma is there's no discernible breast mass. So like with the fibroadenoma, it's well circumscribed, it's painless, and it's you can feel it. It's like a breast mouse. Whereas a with fibrocystic breast changes, there isn't just one. It's multiple, it's all over, and it's in both breasts.
Diffuse.
Yes.
Yeah.
And then for management, reassurance, supportive bra, NSAIDs, and then aspiration if needed.
Yes. And then another thing, sorry about the postmenopausal, did get that mixed up. You're right, it's worse premenstrually, but the pain will subside during menstruation. And then another thing that can exacerbate it is pregnancy or estrogen use,
Yep,
since
absolutely.
it's hormone related.
Absolutely. And then just some memory capsules for you guys. Again, a fibroadenoma is one mass that's painless, and fibrocystic breast changes are multiple cysts that are painful.
Perfect.
Okay. Guess I'm back in the hot seat, huh?
You sure are. You have 30 seconds to tell me all of these things that you know about galactorrhea and go.
I'm drawing a blank, y'all. Galactorrhea is abnormal milk production. It can be caused by medications, a pituitary tumor, symptoms, milk production. You can also have menstrual changes. Diagnosis, usually clinical, because someone's coming in complaining of milk production and they're either not pregnant or they're male or whatever the case may be. Um, and you would also do like labs, to find out the cause. And then for treatment, then um, you're going to then treat the underlying cause. So if it's medications, remove them. If it's a pituitary tumor, or a pituitary adenoma, remove it. And yeah, I
Do
think
you know one of the meds? Because this is a common test pants question, and like you world and all of that. Do you know one of the meds that they use to treat it if it is a prolactinoma cause?
I knew he was gonna say. I knew he was gonna ask me that. Oh, I
They're
know the
weird.
meds.
They're weird words.
I can't think of I dopamine agonist,
Correct.
and they are oh I had a mnemonic. It was like oh,
Okay.
Caberline and bromocriptine, I think are the
Yes, you got it. You got it. Bromocriptine and cabergoline. Yeah.
cabergoline. I think the
Yeah.
mnemonic I made up was like
Bro,
cat
call me a cab.
carburetor or something.
Yeah. Bro, call me a cab. My nipples are leaking. Yeah.
Yeah. Oh yes, bro. Call me a cab. My nipples are leaking. Yeah. I knew you were gonna ask me that, and I was like, oh, I'm gonna be ready this time, and I was not indeed ready.
Well, it's fine because you actually got yourself there and I didn't have to tell you. So,
Love that.
yes.
So let me help you out here. There we go.
Okay, thank you. So, galactorrhea, you are right. It's abnormal discharge of milk due to most commonly a hyperprolactinemia. Sorry, that word trips me up every time. Medications are a common cause. A prolactinoma, which is that benign tumor, and then hypothyroidism.
Awesome.
Signs and symptoms are going to be bilateral milky nipple discharge, and you can have those associated menstrual changes or they may not be present.
Awesome.
As far as diagnosis, the labs that you really want to check when you're working this up are beta HCG, prolactin level, and TSH level, and then MRI of the pituitary if prolactin is elevated, because then you want to see, like, is there a tumor there causing this elevated prolactin?
Absolutely.
which usually it is. And then Jade was absolutely right. Treat it by either removing that prolactinoma, which is the cause, and then your dopamine agonist, cabergoline and bromo.
Absolutely. Awesome. Awesome. Okay. Gynecomastia.
Alrighty.
Tell me
So,
everything you know.
okay.
Go ahead, you said.
Gynecomastia is abnormal size of breast tissue in male patients. It's due to like excess tissue production behind the areola. Most common causes are going to be medications, specifically spironolactone. That's like the buzz one that's always on all of the questions. And on physical exam, there will be this like extra tender, firm area under the areola nipple area that is just fatty. It's different from the just male breast enlargement. It's an actual area of firmness underneath the areola. Labs, you're going to want to test your testosterone levels. And then for treatment, it's going to be treat the cause, which is removing that medication. And then you can excise it if it becomes too problematic, but usually it resolves when you remove the medication.
Absolutely, absolutely. You hit it pretty well much on the nail. So, patho, so it's a benign glandular proliferation from increased estrogen to androgen ratio. So, there's more estrogen in the body than there is testosterone. A tender, firm tissue under the areola, unilateral or bilateral. Labs, like you said, testosterone. You also want to get an estradiol, an LH, FSH, and a beta ACG. And then if it is suspicious, because we know that males can also develop breast cancer, you want to image it because usually gynecomastia is seen in males because it's an abnormal breast tissue growth. And women, we already have breast tissue. So 9 times out of 10, the person that's coming into your office will be a male or a biological male. And they are having this tissue. And so if you feel like it's suspicious or if they're having any of the B symptoms, fever, weight loss, night sweats, you definitely want to get it imaged. And then treat the cause, like you said. So you're going to treat the cause, you're going to observe. You can also do tamoxifen, and then if it's persistent, you do surgery. All right. Mastitis.
Alrighty, you're back in the hot seat, Jade. Tell
Sure.
me everything you know about mastitis in about 30 seconds.
Okay. So patho, the most common cause, again, staph loves the breast, I guess. I don't know. Maybe
Staph loves the skin.
staph loves it. If it's on the outside of your body, staph loves it. You know, when in doubt, staph it out. Yes, Staphylococcus is the most common cause. Staph aureus. It is it's a localized infection of the breast, usually complication of breastfeeding. Symptoms, you'll have painful, like tender swelling on the breast, and then you'll probably also have fever. Diagnosis, usually clinical. You're also going to get some labs. And then the treatment you would treat with antibiotics and encourage continuing of breastfeeding.
Perfect. You hit it on the nail. What is a complication of mastitis? What can arise as a result of mastitis that we talked about earlier?
Breast abscess.
There you go. Perfect, which is also staph. And I think I made an error earlier. The medications for if you're not suspecting staph in mastitis are going to be dicloxacin and cephalexin. I believe I said clindamycin. Clindamycin would be one of the meds if you are suspecting MRSA,
Okay.
along
Okay.
with zinc if it's severe.
Yes. Yes. Yes.
Yeah. So as far as the infection, again, it's infection and inflammation of the lactating breast, usually Staph aureus. So just think about it. A woman is breastfeeding, the fetus or the infant is suckling on the nipple, causing it to get cracked. There's staph, it lives on our skin, it goes into those crevices, and boom, you have a mild infection. As far as symptoms, unilateral pain that's usually on one breast at a time. You'll have that redness, that erythema, that warmth, and fever. And clinical, it's usually clinically diagnosed. You can pretty much tell by a good H&P, which PAs are known for. And if you need a little assistance, an ultrasound can help, especially if you're suspecting that abscess. And again, you will see that hypoechoic area in the ultrasound, which is just a dark, very dark, usually round or lobular area in the ultrasound. And then as far as management, continue to breastfeed. That is going to help get that stagnant milk moving. It's going to help flush out those ducts and get you back to normal, as well as warm compresses and NSAIDs, and then your antibiotics, the dicloxacin and cephalexin. If it's MRSA, if you're suspecting it's MRSA or the mom has a history of MRSA, we're going to do TMP SMX, which is Bactrim, as well as clindamycin. And if it's severe MRSA, we will consider vancomycin.
Absolutely. The only thing about vancomycin, though, I just want to jump in, is that it is teratogenic. So you do not give it if they are breastfeeding.
Correct.
They have to stop breastfeeding before you give them the vanc.
Correct. And I'm pretty sure if it's that severe of an infection, she won't even be able to breastfeed.
Absolutely. Okay, so we are going to kind of pivot here. So, breast cancer is a very broad topic and it is very high yield. So, we're not going to do as big of hot seat as we did for the smaller topics just because there's so much information and we want you guys to kind of get a big picture of it. And so, we'll just kind of take turns like asking each other questions, but really just kind of talking about it because, again, there's just so much information just in one like category, and so we don't want this video to be 30 hours long. That's an exaggeration, but because there's just so much stuff, we just want to make it as very high yield rapid as possible while still being as detailed as possible.
Great.
So, breast cancer, the big picture. So we know most common cancer in women, excluding skin cancer is the most common cancer, period. And then it is the number two cause of cancer deaths in women after lung cancer is the number two cause of cancer death. Period. The median age for breast cancer is about 60 years old. So, Autumn, can you tell me some of the major risk factors?
So, major risk factors are going to be family history. That's a huge one, and then estrogen exposure. So, think about it. Early menarche, when you start your period at a younger age, like 8 or 9, you're having a longer exposure to estrogen than somebody who might start at age 15 or 16. And that also goes with late menopause. If you go through menopause at around 60 years old, as opposed to the average woman at 51 or 52, you also have increased estrogen exposure, as well as null parity, which means you don't have any children, or yes, null parity. And then also hormone replacement therapy. Say you have been on hormone replacement therapy or for any other women's health issues that you've had in your life, you also are at an increased risk. And then with any cancer, you also have obesity as a risk factor. And when I said the family history, that's a first degree relative. So that's going to be your mom, your aunt, or your sister.
Okay. All right. Awesome. And you did pretty much hit them all. So the one thing you did forget was prior chest radiation, especially before age 30. So if you broke a rib and you had an x-ray or you get multiple x-rays or for whatever reason your chest is being extremely exposed, especially us as PAs, me specifically, as an ortho PA in surgery, we are exposed to radiation all the time, especially with the C-arm and the mini C-arm when we do surgeries. And so that's why we have to wear that lead that goes across our chest and then the thyroid shield because that's chest radiation, that's chest exposure to radiation, and so that can cause, especially for before age 30, that can also be a major risk factor for breast cancer.
So
So
think like if you have a patient who has had multiple bouts of pneumonia, they're probably getting chest x-rayed every time they think they have pneumonia at the urgent care or the emergency department. So just keep that in mind.
absolutely. So if you get a question on the pants or on your EORs or on your end of curriculum exam, and it says something, along the lines of a person who has a history of recurrent pneumonia or COPD or something,
Cystic
um,
fibrosis or
fibrosis or anything like that, and they report a history of constant radiation exposure or X-rays, keep breast cancer on the differential if they mention a breast mass or anything like that. So yes, you hit it on the nail. They're both hormonal and genetic risk factors. So we think estrogen exposure as hormonal, and then family history. So early menarche, late menopause, null parity, or late first pregnancy. So if a patient comes in and she didn't have her first child until she was 50, and now, she is complaining of a breast mass or whatever the case may be. That late first pregnancy just exposes her to estrogen longer. Um, Hormone replacement therapy or oral contraceptive pills, obesity, because the estrogen is converted in the periphery in the adipose tissue. Obvious, and then for family history and genetics, we have BRCA1, BRCA2 mutations, a first degree relative, and again prior chest radiation. So very good, very good.
awesome. So Jade, tell me a little bit about breast cancer screening. What does the U.S. Preventative Task Force recommend?
So for breast cancer screenings, I'm not even gonna try to say exactly what you just said because my brain won't function. But they recommend at age 40 to get it every 2 to 3 years, mammogram, and then for those younger than 40, you want to do ultrasounds if you have anything suspicious or fibroadenoma or anything like that because um, it's limiting, again, chest exposure. And then um, you can also do self breast exams, which is optional, but it's highly recommended in medicine. However, Autumn, I remember you telling me something a couple days ago about how they're trying to shy away from that.
Yeah, just with the I read something, and don't quote me on it, but it's not helping the issue, I guess you can say, doing the self breast exam. It's not as heavily pushed as it was when we were growing up or just 10 years ago. So maybe I can add a little something at the end of this where I found that at, just to let you guys know.
Yeah, definitely. Me personally, as a provider, even though I'm in ortho, I'm gonna still recommend you to do your self breast exams because more breast cancer is caught by themselves. More breast masses are caught by the person than they are in the doctor's office. It's pretty much dismissed in the doctor. Oh, you're fine. It's just a cyst. But no, you can't advocate for yourself if you don't even know it's there.
And you know your breast better than anyone else. If you're feeling it every month in the shower, you will be able to catch if it's bigger, smaller, moved, mobile, fixed. So I personally still recommend them as well until the USPTF knocks on my door.
Exactly. All right. So yes. So mammogram,
Yes.
age 40 to
Mhm.
74, every 2 years. That was my bad. I said every 2 to 3, but every 2 years. Um, I forgot MRI, which is for high risk for BRCA mutations, and that's more sensitive, which we know that MRIs are typically the more sensitive imaging modality, anyways. And
Yes,
then, like we said, the self clinical exam, optional, but highly recommended, at least by us.
correct. And it's not proven to decrease mortality. So basically, you doing breast exams is not going to, you know, decrease your rate of mortality, your risk of mortality.
Absolutely. Okay. Now, Autumn, do you know the most tested, pants-worthy, tested types of breast cancer?
I know two of them because I always see them.
Can you
So,
give me the two you got?
just off the dome, the most common type of breast cancer is going to be infiltrating ductal. That is going to be all across on your pans, on your EORs, EOCs, everything. And then the worst prognosis is going to be your inflammatory breast cancer.
Yes. Yes, yes, yes. So, we have non-invasive or in situ, which Pearl, for those who are wondering what like in situ means, because I know that we had that question in PA school. In situ, just think in sitting. So in place. It's in one area. It's not, it hasn't migrated, it hasn't metastasized. It is in sitting, in situ. And so those are your non-invasives. So we have your ductal carcinoma in situ, and it's confined to the ducts. It's so you'll see the micro calcifications on mammograms, and then we have the lobar carcinoma in situ, and so that's the risk factor for bilateral. You'll have a risk factor for bilateral invasive cancer if you have carcinoma in situ because it's in the lobe. And then we have our invasive or infiltrating. And so the most common, like she said, infiltrating ductal carcinoma, our IDC. And if you guys saw our Med Monday, our memory capsule, IDC, think it's the default cancer. So 9 times out of 10, the person will have infiltrating ductal carcinoma. Think every woman's ducts can get cancer, essentially. So it's the most common. It'll be a firm, immobile, irregular mass. And then we have ILC, which is invasive lobar carcinoma, which is often bilateral. And then on histology, you'll see single file cells. And then we have inflammatory carcinoma or inflammatory breast cancer, which is the most deadly. And think inflammation, it burns completely. So, inflammatory breast cancer, it burns completely. So, it spreads like wildfire. It's very, very, very deadly. It's the highest, has the highest mortality rates. And on exam, you'll see a Pudet orange, which we'll talk about, which Pudet orange is skin thickening. It kind of represents an orange peel. And you want to suspect this if a patient comes in and they have this like like it looks like an orange peel, and you're like, oh, maybe it's just an infection. So you give antibiotics and it doesn't, the antibiotics don't do anything. Then you want to suspect inflammatory carcinoma. And then so you'll have the erythema, the edema, and then it's a poor prognosis. Again, it's the highest mortality rate. And then we have Paget disease of the nipple, which basically looks like eczema around the nipple. And with that, you're going to think, okay, they might have underlying carcinoma with Paget disease of the nipple.
Yes, and I just have a few things to add. Thanks, Jade, for hitting on the tip about the failed antibiotics. On your pants or any questions that you're answering, it is easy to get inflammatory carcinoma mixed up with your mastitis because they're kind of presenting similarly. You won't see the Pode orange with the mastitis, but a lot of the other things, the erythema, edema, it's going to look the same. But if they have already trialed antibiotics and they're not working, you want to think inflammatory carcinoma. Um, and then also, the main things that you're going to want to pick out of this slide are going to be the infiltrating ductal, the inflammatory carcinoma, and the Paget's disease. Those are the top three tested, but it's still good to know all of these because, again, these topics were part of that PANCE blueprint, so they're fair game. You might not see them as much, but they could pop.
Absolutely. All right.
Alrighty. So receptor types. I am not the strongest with this category. I will tell you guys that. But it is good to have a quick briefing on them. So I will go over them with you guys. So you have the ER positive and the PR positive. So that's just estrogen receptor positive and progesterone receptor positive. These are your hormonal breast cancers. They have the best prognosis, and usually tamoxifen or aromatase inhibitors will help with these types of cancers. Next, you've probably heard of this before, HER2 positive. Let me tell you, I had no idea what this meant. Even before school, during school, I just heard it and it just confused me. But that's your hormone estrogen receptor positive breast cancer. It's aggressive, and it warrants this lovely medication right here. Jade, I am not sure how to pronounce that. Can you give it a
Parasect.
stab? Okay, good.
Parasect.
Okay, love that. That is the brand name for that, or
Yes,
the
I'm not
gen-
gonna try to pronounce the generic. You guys see it. It's trastuzumab. It's a
trastuzumab.
mob.
I can tell you that it's a monoclonal antibody
Absolutely.
because it
But
ends
that's
in mob.
yes, but that's
Yes.
I'm not gonna even try to butcher those names. But and usually on the pants, um, I didn't have any questions about it. They really won't really test you on breast cancer medications. They just want to know that you know them or you know that it's HER2 or estrogen receptor or
Or
uh,
they might put the med, but they might put it with other meds that you know aren't right, like a beta
absolutely.
blocker, and and then oh, this is an aggressive form of breast cancer. Let's give them a biologic. So if you see anything that ends in MAB, that's a biologic, a monoclonal antibody. You select that. And then the last one that we're going to go over is a triple negative. So that's ER negative, PR negative, HER2 negative. That is the worst prognosis type of breast cancer, and that warrants chemotherapy, unfortunately.
Yep, absolutely. And all right, so some clinical features of breast cancer. Um, this differs from a lot of the benign neoplasms that we talked about because they're going to be painless, like a fibroadenoma. However, these are going to be immobile. They're going to be fixed. They're not going to move, and they're going to be hard. And then you may see some skin dimpling or nipple retraction because those cancer cells are pulling down on on the skin. You can also have some axillary lymphadenopathy. I'm so sorry, guys. My tongue is tied. Some axillary lymphadenopathy, and that's because the cancer cells are now going into your lymph nodes, and the closest lymph nodes to the breast are the axillary lymph nodes. Um, and then you can have some nipple discharge. So if you have bloody nipple discharge, that's always concerning. And then sometimes you don't even know. And this is again why self breast exams are so important because sometimes it may just be an incidental finding on a mammogram. You might go get your regular mammogram that day, and because you didn't do your breast exam or because it's so small, they don't see it, and then they go do your mammogram, and you're like, boom, cancer, and they're like, oh wow, like so. Sometimes it's just an incidental finding.
Yep. And along with those self breast exams, the axillary lymphadenopathy. So when you're doing your self breast exams, you want to go all the way up. I don't know if you guys can see me, but through into the tail of Spence, which you should know that from anatomy class, because some of those hard lumps can be hidden up through here.
Absolutely. And then real quick for diagnosis and treatment.
Okay, so first, the first lines are going to be your mammogram and ultrasound. Ultrasound is actually going to be first. Mammogram is recommended at a certain age, but if you have any, like we said earlier, any suspicious masses or lumps, you're going to start with ultrasound. And a huge, this is a sidebar, a huge, I don't know the word, it's blanking me right now, but a debunk, I guess you can say, is that mammograms cause breast cancer. And a lot of women are like, I don't want to go get a mammogram because that's too much radiation. I'd rather just wait. No, you need to get your mammograms at your stated time. There's different time variables for if you have a first degree relative, you might need to go earlier. But you get less radiation from a mammogram than riding in an airplane on vacation. Look that
Hmm.
up when you get some time. So just please get your mammograms, ladies, and men, if there's anything suspicious, because this is not conclusive just to women. Next is going to be a core needle biopsy. That is going to be definitive. When you go in and biopsy those actual cells, you will see the cancer. And then fine
And
needle.
real quick,
Sorry.
sorry, I didn't want to interrupt you,
Yeah.
but I wanted to say it before we lost it. What is the mnemonic that is for biopsies in general?
Um,
Tissue is the issue.
Tissue is the issue. Yes, tissue is the
Yeah.
issue. So
So
if
for any, yeah,
yeah, if you are suspicious of any, it could be thyroid, it can be a lung nodule. Tissue is the issue. You get in there, you get a sample of it, and you test it. Um,
absolutely.
and then fine needle aspiration, similar. Diagnostic is limited. It's diagnostic, but it's limited because there's no receptor testing. And then as far as treatment, if it's localized, meaning no metastasis to other areas of the body, there can be a lumpectomy, which is where that specific lump is removed, plus radiation to that area or nearby areas. If it is larger or multifocal, so we're stepping up, mastectomy plus or minus reconstruction, that is up to you and your surgeon and your funds and all of those things. You will see some women who have had a full reconstruction with implants and some women who choose to just keep their scars. And then you have node positive slash HER2 positive slash triple negative. As we remember from a few slides back, you're getting more aggressive. So we're going to have all of those other options plus adding a chemotherapy option, which again, the PANCE will not test you on those drugs, but just knowing chemo is the answer is what you need to know. And then estrogen receptor and progesterone receptor positive, we're going to have the addition of hormone therapy with tamoxifen or an aromatase inhibitor.
Yes, absolutely. And I
Because
just
that
wanted
can
to just
help.
add,
Yeah.
I just wanted to add real quick that like when we mean node positive, we mean that it has metastasized to the lymph nodes um, in the axillary region, or lymph nodes really anywhere,
The
like in the chest.
lungs, the brain. Yeah.
Right. And then some pearls. So we know that when you get a mastectomy during like when you have breast cancer, you get a mastectomy. They usually take the lymph nodes from the axillary region. Again, it can metastasize up there, and so when you get the axillary node dissection, lymphedema is a very common complication, and so that's why sometimes when you see patients come in and they wear the compression sleeves, a good history. It's good important to take a good history because you can ask them, "Have you ever had breast cancer before, or have you ever had a mastectomy where they remove the lymph nodes?" Because that will be the explanation for the swelling, especially if the provider or the surgeon didn't explain that, which usually they should, but sometimes they can forget or whatever the case may be, and someone will come in and be like, "Oh my gosh, my arm is just swelling, and I just had surgery on my breast 3 weeks ago. Now my arm's swelling up." Lymphedema is a very common complication of that. You for recurrence, you want to do annual imaging, and obviously at your physicals you do your breast exam. The most common location is the upper outer quadrant, so that's the most common location for breast cancer. And then again for Paget's disease, it'll be an itchy, scaly nipple lesion, and you want to be concerned for underlying DCIS or invasive cancer. And then for inflammatory carcinoma, think pewter orange, fast progression.
Yes. Those are good pearls to know. They will pop up.
Absolutely. So that is it for our breast disorder.
So, this was a tribute to Breast Cancer Awareness Month. And as we know, it's always Breast Cancer Awareness. This is not just an October thing, but we just wanted to take time in the month of October when you see everyone wearing the pink and doing the walks and runs to actually educate. Because a lot of people, they go support the runs, but they still don't know a lot of this information. So, if you know it, you can teach it. Each one teach one. And this will not be the last of breast anything that you see from us. We just wanted to kind of prioritize it this month since it is special.
Absolutely. So we hope you guys really enjoyed this and we hope that it was helpful. If you have any questions or anything that you need clarified, please don't hesitate to reach out. Our DMs are always open and we're open to hearing your suggestions. And if you think we should add anything or take anything away, we're open to it all.
Awesome. Thanks. And as always, we'll see you guys at your next dose.
Yeah.